All right, we're good. Go ahead, Mike.
Okay, so one of the things I'd like for us to do today, I know that Damon and I had actually spoken prior to this, but we were having a little bit of technical difficulty. What we want to look at doing was going into the Advanced MD system and creating a client titled Mental Health Assessment with the last name cheat sheet. And what we were going to do was we were going to go through the mental health assessment by non-physician. And we were going to create a cheat sheet based off of the sections that are responsible for completing. But needless to say, technical difficulty.
Mike, it's up. I've got it up. It's done. We're ready to do that.
Oh, we're ready to do
Yeah, I'm sharing my
that.
screen.
Okay.
I called it assessment sheet. That's the guy's name. So if you look at your screen, you should be able to see my screen, right? So you got a blank assessment to start with.
Okay, fair. That's great. Can you make it a little bigger, Damon?
Good?
That'll work. Yep, that's good. Okay, now, as with intervention and the clientele that we work with, there's different, I guess, frames of reference that are present in regards to treatment and intervention. I'm of the opinion that from the very first moment you meet with your client, which would be for the assessment or the assessment phase, that's when your treatment and intervention actually commence. That's when it starts. Now, the assessment serves multiple purposes, but two of the primary ones that you hear us talk about the most is in regards to data collection for diagnostics, as well as data collection to ensure that medical necessity is met. You know, it's a fickle beast in regards to this Medicaid stuff. We've got to make sure that medical necessity is met. Now, one of the things that I've encountered or that I identified when I was going through a huge book of assessments was that within the assessment itself, it seems like there's certain things that are getting lost. And what I mean is I want you to approach this assessment as being like the frame of a picture. And each section, what you're doing is you are filling in a portion of what that total picture is going to look like. And then when you get to the end, you should have a complete picture painted. Now, I'll be the first to admit to you, there are going to be times when you may get to the end and there are still sections of this picture that are blank. But even when that's the case, the way that Damon and Scott and I have structured this assessment template, you still should have a pretty good picture as to what is going on, even if during the course of treatment or the counseling session itself, you have to back up and sort of fill in components of that picture. Now, at the top of this template, you've got your date of birth and your clinician name and referral source and things of that effect. And then you've got the reason for referral, which to be honest with you, there could be times when we have clients where there's multiple ones checked, whether it be mental health or abnormal behavior or things to that effect. But that's sort of self-explanatory, and that just get as specific as you possibly can. We all are aware of the fact that trauma is going to be indicative of mental health, or that personality disorders are mental health, and personality disorders are symbolic of abnormal behavior. So check the one that's most appropriate at that time based on the client that's in front of you. Of course, if this is the initial assessment, the assessment is being provided to determine the need for, which is the next week. Well, yeah, Damon's on reassessment. If reassessment indicate the reason. But since this is not a reassessment, it would just be the initial assessment itself. The need for, if I could get you on that next one, Damon. Outpatient therapy is substance abuse treatment. You know, again, pick the one that's most appropriate to the client that's in front of you. Frequency, presenting mental health issues disclosed above are present as follows. The frequency, more than once a day, multiple times per week, once per week, multiple times per month. Again, on that one, you just check the one that's most appropriate based on the presenting scenario or situation. Now, if you check when you check one, try to be as specific as possible under the description. If you state that it's occurring multiple times per week, try to identify patterns of presentation. Are they occurring more often in the mornings, in the evenings? Are they occurring when the person's by themselves? Is it only occurring when there's other people or persons present? Try to get as descriptive as you possibly can in regards to when the symptoms are occurring. Also, specifically as it relates to symptoms, a client who, let's say your client is a child, you noting that the client has been exposed to abuse or neglect by the caregivers, that is not a symptom. That's a descriptor, but it's not a symptom. Symptoms would be difficulty sleeping, sporadic appetite, lack of motivation, crying episodes, feeling overly emotional, maybe crying and not knowing why they're crying, easy agitation or frustration, defiance towards authoritative figures, nightmares, daytime daydreaming or disassociated features. It could be, those are the things that we're basically looking for here under that description of symptoms. And they are what is going to be running the basis for the medical necessity. Not to say that, for instance, a patient who was sexually assaulted isn't relevant data to have within the assessment. But keep in mind that we're looking for like specific symptoms. So let's say at the top, if you would have checked trauma, then under the symptoms, you'd be noting the specific symptoms associated with that trauma. And of course, you would want to, if you're aware of it and the client is aware of it, you're going to want to note what that specific trauma was, because that would be the difference between, let's say, you have symptoms, but you don't have enough to meet criteria for PTSD. If you know what the symptom is and you as the clinician are going to identify what that trauma was, well, that's the difference between unspecified and specified trauma and or stressor-related disorder. Now, keep in mind that particular diagnostic is primarily utilized when your patient is presenting with symptoms or features of post-traumatic stress disorder, yet the client hasn't disclosed or you, the clinician, haven't identified specifics that meet the DSM-5 criteria for PTSD. And I'm just using that as an example. Now, when you are diagnosing somebody, not only do you need to know what the symptoms are and have the symptoms specifically listed, but you also got to have some other information as well, such as the onset or the duration of the symptoms, the frequency of when those symptoms are occurring, because that's going to be your basis behind how these symptoms are disrupting your patient or your client's functioning capacities. So again, be as specific as possible. If you just check multiple times per week, and under the descriptor, you are just simply rephrasing that it's occurring multiple times per week, the reader of this assessment is going to know that the presentations are occurring multiple times per week, but it's not really going to give them a whole lot of information in regards to what that specifically looks like. Remember, everything that you're typing and the data that you're collecting, you're filling in the picture frame. So as specific as you possibly can, that's what you need to shoot for. Now, I know sometimes we as individuals, when we're the ones typing up these assessments, we have all the information in our heads. But when we type, sometimes we fail to include things because it's already there in our minds. We need to keep in mind that other people are going to be reading this assessment. And since they're not the ones who completed the assessment, they need to know what you know in regards to the data you have collected. Yeah.
Mike, are you able to see what I'm typing as you're talking?
Yeah, temper tantrums occur on average once per day. Crying episodes occur every time a temper tantrum occurs. Verbally describes wishing to be dead about 2 to 3 times per week following the tantrums. Yeah, get as specific as you possibly can. And, I mean, that's what you're typing, Damon, is more than fine. It's more than fine. From frequency, the next place you've got to go is duration. Now, duration is just as important as the specific listing of symptoms. The reason why it's important is because, let's say if you have a person who presents with difficulty sleeping, lack of motivation, crying episodes. Okay, so let's, just based off of those symptoms I've identified, we meet criteria for some form of depression. Now, it's possible if 1 or 2 other symptoms are present, you might have anxiety. But just looking at those 3 examples of symptoms, let's say that we know that it's depression. Damon's checked 30 to 90 days. What does that circle checked automatically imply? What does that automatically tell us about the diagnosis that we should be looking at right from the get-go, just based off that one circle that's checked 30 to 90 days? What does that tell us?
I think
complex depression.
I'm sorry? What was that? Sandy, was that you?
Yeah, complex depression.
Well, it could, but what that tells you in terms of duration is that these symptoms have only been occurring from 1 month to 3 months.
I was thinking it wouldn't be long enough to diagnose depression. Am I correct?
Well, no, I mean, it could be, but 30 to 90 days are what you should be looking, or what you should be thinking about is if your client says everything was fine, but for the past 30 to 90 days I've been experiencing these symptoms, bam, 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 bam. What that should automatically tell you is that based off that specific data, you're looking at acute versus chronic presentations. What's the difference between acute and chronic? Acute implies that the potential exists for the symptoms to be presenting as a result of the situation, or that it's situational, or that it's adjustment, or that it's not been present long enough to substantiate a chronic finding. And as a result, that's going to have a direct impact on your intervention or treatment. If you have an individual who's presenting with symptoms, and those symptoms have been present for more than 2 years or 24 months, well, then chances are the symptoms have, how those symptoms have impacted that person's level of functioning is that now you have to take into account, being the counselor, that that there has been some manner of impact on the client's character or personality, or that some form of restructuring has occurred on behalf of the client as a means of how they have coped with those symptoms since they've been there for that long. Whereas if you have a patient who's reporting these symptoms have only been there for 1 to 3 months, then chances are that not to say that it couldn't occur or on some level occur, but chances are what you're looking at is more of an acute or an adjustment type situation, which is going to have a direct impact not only on your diagnostics, but also on the manner in which you are rendering intervention or treatment to this particular person. Does that make sense, guys? Are you following me? Like, for instance, let's say you have a person who's presenting with those symptoms. Let's say there's several more, low self-worth or poor self-esteem. But what they're describing is that even though these symptoms are there, it doesn't really prohibit them from functioning. It just makes it more difficult. So in essence, you're looking at a low-grade chronic depression if those symptoms have been there for more than 24 months. So now you're looking at like persistent depressive disorder or dysthymia. Whereas if those exact same symptoms were present, but they've only occurred for 30 to 90 days, just off duration alone, you don't meet criteria for persistent depressive disorder or dysthymia. All you've got is you have to take into account either major depressive episode or unspecified depressive disorder or adjustment disorder with depressed mood, because the duration that the client's reporting rules out the chronic persistent depression that you'll find within the DSM-5. The symptoms can be identical, but you got to then take into account the duration of as to how long these symptoms have been there, as well as the direct impact of functioning on the person. Prime example, you can have a major depressive episode, or a person present with a major depressive episode within 30 to 90 days, which coincides with the duration of an adjustment disorder with depressed mood. So how do you differentiate between those two? It's going to be impact on functioning. Like, for instance, not to say that you couldn't go with an adjustment disorder with depressed mood based off of duration, but there should be other variables that are taken into account. And there might be instances, guys, when you are meeting with these clients and you might not be able to get everything that you fully need to get within this assessment session. I'm sure that's happened to all of you at some time or another. It's happened to me. So what
Mike, I've actually have a client that I just done an assessment on Friday, and she's her functioning as far as going out into public and everything has come to a screeching halt after her dad passed away.
Okay.
And I done like what you were saying. I think there's more to it. I mean, she quit taking baths. She doesn't work. She doesn't go to school. She doesn't leave the house. And her basic level of functioning has gone to almost nothing. And I had, and you can look at it, I'm sure, I'd done like what you said. I'd done the adjustment with depressive mood.
Right.
But as you said, I think there are more things that I'm going to find out when it comes to this. When we do find those things out, is that something that we should tack a note onto this assessment?
Absolutely. Absolutely. Like, I would anticipate in that particular situation, Shandy, that you would go with an adjustment disorder with depressed mood, but then you find out more information that leads you to believe that, okay, even though it might meet duration criteria for adjustment disorder, and that diagnosis is appropriate. When I say appropriate, I mean meets DSM criteria, but then you find out a little bit more information, and now you've got enough to where you can justify a major depressive disorder or a major depressive episode. Then you would add a note to the file, identifying that specific modification. Since you can't go back in on an assessment after you've completed it and signed off on it and reviewed it and submitted, you can't go back in and make specific modifications to the assessment. The only thing that we could do then is just add a note stating that, client initially met criteria for adjustment disorder. However, or although criteria for adjustment disorder with depressed mood continues to be accurate, additional data to include appears to indicate the more appropriate diagnosis as being a major depressive episode. So, yeah, Sandy, that's exactly what you would do.
Now maybe you or Damon can answer this question. When I went back in and I had got your notes and I was working on some of these that I had diagnosed in the past, I found something in the template called a backup assessment. And that's where I'd done these adjustments to where I had been off on the assessments. Is that feasible? Is that what we need to do?
Well, the backup assessment is just there in case I accidentally delete the original assessment. So it's just a copy for me. You can continue to use the regular assessment whenever you're making adjustments.
Okay, because it had a place to where it would notify Mike to sign and everything. That way, I knew it would, he would see it.
Yeah.
Right. Now, I'm under the assumption that everybody has a DSM-5. Is that correct? Is there anybody who's attempting to do this by way of just using an online, like an online like DSM type in, or does everybody have like a DSM actual book?
I don't have a DSM-5. I have the older model.
The DSM that I use is online, but it's not a plug type deal. I got it through Liberty. It's through it's the whole book.
Okay. And who said that they're using the older model? I guess you're talking about like the DSM-4 TR. Is that what you're referencing?
That's the book I have. This is Shannon.
Okay. The several things I would point out to you in regards to using that DSM-4. Like for instance, there are some pretty significant revisions, but if you are utilizing the DSM-4 TR, if I'm not mistaken, when you type that in on Advanced MD, the DSM-5 codes actually pop up too. So just make sure that you're clicking on the DSM-5 actual code title. That way we can stay in compliance with APA and the ICD-10. Okay.
Sorry.
And also keep in mind that certain diagnostics in that DSM-4 TR that you're using are not found in the DSM-5. The example that pops into my mind now, Shannon, is the DSM-4 TR, like the polysubstance is listed in the DSM-4 TR, which is if you have somebody who's abused 3 or more substances simultaneously, you don't have to list all 3 out. You just list polysubstance. But in the DSM-5, that diagnosis no longer exists, so you've got to list each one of them out.
Okay.
Okay. So in terms of diagnostics, symptoms, keep in mind the symptoms for the diagnostic classification is in the DSM. Like one of the things that I do, guys, when I'm reviewing these assessments is I look under that top section where it says describe the symptoms. And lots of times I'm pulling several symptoms out of there. But as I continue to read through this assessment, I'm identifying other symptoms that are within the narrative of this assessment that is actually not up there in the described symptoms. So even though they're not there, I'm still having to jot them down, and I'm making note of them But if you can collapse them all together in that describe the symptoms section, it makes it a whole lot easier in regards to diagnostics. Each one of these sections, like you have describe the symptoms, you've got frequency, which translates to impact on functioning, and then you've got duration. All of those things are, and then under duration you have intensity, or describe how the intensity of the symptoms are being presented, which again impacts, that translates over to impact on functioning. Those things have got to be present in order for your diagnosis to be accurate. You can have two clients presenting with the exact same symptoms, presenting with the exact same impact on their functioning, but if the duration is different, chances are the diagnosis isn't going to be the same between these two people. Or you can have two people with the exact same symptoms, the exact same duration, yet if the impact on their level of functioning is different, that may impact their diagnosis as well. Being familiar with the symptoms of the different diagnostic categories is helpful, and it's very good in regards to determining whether or not you're looking at a possible affect or a mood disorder, or if you're looking at anxiety, or if you're looking at some type of psychotic disorder or personality disorder. But if anybody who's familiar with the DSM and the presentations of the symptoms knows that a lot of the symptoms that a person can present with in an affect or a mood disorder category, they can also present with in an anxiety category as well. So you've got to take it one step further and make certain that you are being as descriptive and specific as possible as it relates to these particular symptoms, duration, intensity, frequency. All of those things are the core principles behind rendering a diagnosis. Now, once you've got the symptoms and the intensity and the diagnostics, and you go down to, if I'm not mistaken, the next section you go to is presence of meaningful relationships. Yeah. Now, what this section is doing is it's all everything that's on this assessment template is there for a specific purpose. Again, I'm referring back to the DSM. The DSM, just about every diagnosis within the book has specific prerequisite criteria, and one of those criteria that's pretty much across the board, no matter what diagnostic you're looking at, is the existence of a pattern. What does that actually imply? A pattern implies that you can see the occurrence, and that occurrence has been occurring throughout a period of time. Now, one of the things I look at is a person's level of functioning throughout the span of them living. Like, for instance, data under education. We'll get to that section, but I'm just jumping ahead to use this as an example. Data under education, I want to know more than whether or not the kid is attending school and how many days they're attending school, or if the person graduated high school. Because what that does is that again, the picture frame, you're painting me a picture of what it's been like for this person, because what it's been like has a direct impact on what it currently is like for this particular person. Now, the presence of meaningful relationships. Does the person possess the ability to love? Does the person possess the ability to possess love, not just for themselves, but for other people? Meaningful relationships. You know, Damon, let's see, Cheat's relationship with peers and siblings is stressed to the point that he does not have any positive interactions with his siblings. Cheat isolates himself in school. Teachers report that he does not interact with other children except as requested by school structure, sitting at the lunch table for lunch, and participating in common area activities. Parental relationships are focused on controlling tantrums. Parents are stressed out and find it difficult to find time to positively interact with Cheat at home. I mean, that paints a pretty good picture of what the relationship or the interpersonal or intrapersonal interactions are like for this particular client. You know,
Mike, feel free to suggest any other items that you would want me to put in here.
like for instance, one of the things that I have a tendency to do is let's say Cheat is a child. At some point during the assessment, I might ask Cheat to provide me with the first name of their best friend. And where I'll go from there is I'll ask Cheat why they decided to choose that person as being their best friend. Now, why would I ask Cheat that specific question? There's no wrong answers here, guys. We're talking freely. Why would I ask Cheat that specific question? What am I looking for? Do I really care about the first name of their best friend? No. But what am I looking for?
To see if he even has a best friend? If he's made that connection to want to have that kind of relationship with someone?
There you go. You know, did they choose Joey for their best friend because Joey isn't mean to him, or do they choose Joey as their best friend because he has an understanding of what friendship looks like? Well, we have commonalities, or we have interests, or he's nice to me. It helps to paint a picture as it relates to that specific pattern. Once again, what is it like? But also it helps provide me some insight with respect to what his belief system is, or what principles are present in regards to who he deems as being a quote friend. School performance. Like for instance, some of the questions that I ask my clients in regards to this particular section is of course last grade completed. Did they have friends present? Were they in any special placements, advanced classes, honors classes, ESE classes, or was it just normal or regular classes? Was there an IEP present? If so, what was that classification? Had they ever been expelled from a school? If so, why? Have they ever been suspended from school? If so, why? Is there a pattern of behavioral referrals? If so, why? Was there any extracurricular activity affiliation, whether it be sports or band or glee club or pep squad or cheerleading, whatever? Because in essence, that's going to have merit in regards to, once again, showing the presence of a pattern and seeing how the pathology that this particular client may be presenting with now, how it came to be. Because if you don't understand the origins of what's causing, or the causal factors behind why these current presentations are occurring, and it's going to be very difficult to render what I would consider to be long-term treatment outcomes. Make sense?
Yes.
Okay. And of course, what were their grades like? Were they ever retained in a grade? If they were retained in a grade, that might be a pretty good indication of a potential starting point in regards to why that retention took place. Well, I was held back in second grade. Well, let's say hypothetically, based on age of your average second grade student, that appears to coincide with when mom and dad divorced. So again, we're painting a picture, and we're collecting data in regards to showing how the progression of that pathology may have taken place. From school, we go to employment. Similar inquiry. You know, what I try to do with respect to employment, guys, is I try to go back a minimum of 5 years, if at all possible, 10. I might ask, are they currently employed? If so, where do they work and how long have they worked there? If they've been at the same job for more than 5 years, I might not ask where they worked prior to that. But I try to go back as far as I possibly can. But I want to know not only where they worked and how long they worked, but has there been any patterns of conflict with coworkers? Has there been any patterns of conflict with supervisors? Were they ever terminated or fired from a position? And if so, where and what for? You know, again, we're looking at that impact on who they are and their functioning levels. Not to say that when Damon and Scott and I, we met and we came up with this template, not to say that we're all Freudian, but just breaking it down. Freud said that if you want to determine an individual's overall level of functioning, the two primary areas that Freud said that you need to look at is a person's abilities to love and a person's abilities to work. That implies meaning, that implies purpose, that implies perception of relationships, interpersonal and interpersonal, as well as intimate. I mean, not to say that you can't look at other areas, but I mean, all of this is of relevance. Like, for instance, I think it was Shannon who said that she utilized the DSM-4 TR. Well, the DSM-4 used to use an Axis 1 through Axis 5 format. And if I'm not mistaken, the Axis 4 was the GAF, the Global Assessment Functioning. What two primary areas did the GAF register?
Social, employment, I forget what else.
Meaningful relationships, a person's abilities to love and a person's abilities to work. For a kid, it's education and school. For an adult, it's actual gainful employment. And then the meaningful relationships. So, I mean, those two areas are located within the GAF from the old DSM-4 book. So here we're looking at just social interaction as well, which, again, you can look at it from that specific variable in terms of painting the picture. But you can also, based on the questions that you ask for these sections, it can afford you the opportunities to accumulate additional data in regards to patterns of potential difficulties or barriers, but also it helps you to be able to track pathology in the client, within the client. Again, so you have school performance, you've got employment. Now we come down here to parenting and familial. What we're looking at here, well, y'all's probably getting tired of me talking, but what are some examples of data that we would want to ensure that we have here, guys?
I usually try to include like their family members, because most of mine are foster kids. I include like if they're living with their blood siblings or how many other foster kids are in the home.
Right. Shandy, take it one step further. Why do you do that? Why is that relevant to you?
Because I know a lot of times, like I have a couple that I have 2 and 3 that has came from abusive homes. They have a trauma bond among them. What one suffered, the other either seen or suffered as well.
Mm-hmm. Okay. Somebody else. What other types of information would we want to know here?
What you want to learn, this is Pam.
Yeah.
Okay, what I focus on when I look at families, their type of discipline that's in the home and the dynamics that are as a result of it. There's different types of parenting where you have authoritarian, you have the permissive,
Right.
those type of things. So you want to look at that and see the dynamics of the family, and you want to look at to see if there's one parent, two parents, or if the grandparents are taking care of the children. You know, shame to hear a lot of them in foster care, but there's a lot of people that, interestingly enough, there's a lot of folks sometimes live together, and that might be an aunt and uncle taking care of the child, and it's not even related. Or I had at one time in birth of 3, it was a great-great-grandmother taking care of 5 children. So there's always some sort of dynamic that you're searching for.
And all of it, in my opinion, is relevant. All of it. You know, let's say hypothetically your patient is an adult, and you're asking them information about, okay, so what was it like for you growing up? And in most cases, oh, it was fine, everything was okay. Now you might encounter some that are free-flowing with their experiences that were negative or uncomfortable, but for the most part, oh, it's fine, it's good. Well, great, help me understand what you mean when you say good. And keep in mind, the number one fear that people have is the fear of being exposed. So feel free to ask follow-up questions in regards to clarification. But like in this, you know, what did you have siblings? If so, you know, what number were you in terms of, were you the middle child? Were the youngest child? Were you the oldest child? You know, what was it like? Were you raised by both parents? If not, were your biological parents married? If so, then note that. If they were, but they divorced or separated, how old were you during the divorce or the separation? Following the divorce or the separation, who was your primary caregiver? Was the other parent continuously absent, or did they maintain interaction with you while you were growing up? If so, what did that look like? You know, what was they may even have been old enough to know why the divorce occurred. Was it extramarital affairs? Was one parent drinking excessively? Was domestic violence present? What was their level of exposure to that domestic violence? You know, think of it in terms of, again, you're painting a picture, you're showing a pattern, and the more information that you can collect in each one of these sections, it's going to afford you the opportunity and the abilities to, once again, track that pathology of how this particular client came to be where they currently are. And all of it is relevant. What type of parenting style, like I heard Pam talk about, you know, types of discipline, were the authoritative figures in the home, were they consistent? Were the rules clear? Were they consistently applied? You know, again, all of it was relevant. Well, when I got in trouble, I got whoopings. Okay, well, you know, were they just whoopings or were they physically abusive? You know, because the perception of that particular client is once again, it's going to be relevant. From was extended family involved in your life? You know, again, like we identified earlier, we are trying to identify in the earlier section this particular client's perception of social interaction or their perception, like the example of the little boy, the first name of the friend, trying to determine, you know, or trying to gain insight in regards to what the level of comprehension or understanding of our client is in regards to those interpersonal relationships and interactions. Here within family, asking if the extended family was involved, was what types of things did your family unit do together? Did you have dinner together every night? You know, that type of information helps to see how, well, from a cognitive standpoint, it helps to see how our client may have developed certain schemas associated with their belief systems and patterns. Community functioning, do they attend church? Any community affiliations? Is there any social networking that occurs within the family out in the community? Do they receive food stamps? If there's young children in the home, are they affiliated with Healthy Start programs. What is the kid attending public schools? If they're not in school, do they go to Head Start or Early Head Start? Is daycares affiliated? What, as much as possible, what was it like? Again, painting a picture, like for instance, another thing I might do, just sort of backing up for parenting, but I'm going to show you like an example of one of the questions I might ask is let's say your client you're meeting with your client, you're doing your assessment, and you ask whether or not the biological parents were married. At times one of the follow-up questions I might ask is well, what kind of work did your father do? What did your mother work, or what kind of work did your mom do, or was she a full-time homemaker? Why do you think I'm asking that question? Do you think I'm concerned about whether or not his father worked in construction, or the father worked for the state of West Virginia road crew? But what am I looking for? What does that answer? What can that answer afford me? Anybody?
Are you asking the question, like who was the primary disciplinarian or who was primary caretaker? Is that what you're asking?
I mean, I'm just giving an example of like when I'm assessing, I might ask the client, what kind of work did your father do? Why am I asking that question? Or what kind of work did your mother do? Why am I asking that question? What information can I gather by asking that question?
Well, what you can gather is what type of socioeconomic status the family may be in.
There you go. Now, which do you think I would get more information from? Asking my patient what socioeconomic status their family was, or asking them what kind of work their parents did? Like, for instance, if let's say my client is a younger female who's been married. Let's say I frame up the question of, gosh, what was it like for you on your wedding day? I bet your daddy wanted to jerk a knot in that old boy's hind end for marrying his little girl. And then she says, well, my dad wasn't there. What does that tell you? Of course, you need to go a little bit further and clear information. But in essence, what I'm talking about right now is the manner in which you are interviewing and utilizing data collection. There's two primary types. There's the front door approach, is where you're blunt and you just simply ask the question, what was your relationship like with your father? Or there's the back door approach, where you frame it up about the wedding day and ask, what did your daddy want to jerk a knot in that boy's hind end? Well, dad wasn't there. So, I mean, keep that in mind, that not only is there a science to this with respect to interviewing and assessing, but there's also an art form too. Again, like I stated earlier, the number one fear people have is the fear of being exposed. And therefore, your inquiries need to be completed in a way to where they're less threatening, or they're not perceived as being aggressive. And sometimes that front door approach works fine with clients. And other times there's clients that the front door approach isn't going to work. So you're going to have to collect your data by means of as it coming across as like just a conversation. And again, there's an art form too. But at the same time, you can ask questions, and the questions that you're asking might not have relevance in terms of the wording that you're using in your question. It's the underlying variables associated with your question is what you are utilizing as your primary measure. Does that make sense, guys?
Yes.
Okay.
Yes.
Again, community functioning, the things that we identified. Does the client have a prior history of mental health treatment? You know, if that's a yes, then, you know, when was it? Where was it? What was it for? You know, and not in this particular section, not only are you trying to collect data about prior interventions or treatments, which of course could be linked to diagnostics or treatments and interventions, but you know, it also this section also affords you the ability to gauge self-efficacy in terms of follow-through, goal creation, whether or not they completed it. If they completed it and their perception is that it was successful. Were they non-compliant due to reluctance or resistance? You know, I don't know how many assessments I have read throughout the years where it talks about patients and their pattern of non-compliance based off of previous interventions or treatments that were implemented. You know, all of that is relevant, not just the successes, but also the potential failures due to whatever the reason was. Was there prior inpatient admissions? You know, just get as specific as you possibly can. This section is here. Let's say your patient presents with reports a history of depression and that they were previously on medications and they had previously had an inpatient admission, and however, the past 2 or 3 years they deny the presence of any kind of symptoms associated with the depression. You, from a diagnostic standpoint, you could still diagnose with depression, but adding the specifier of by history, which means that you are reporting that the client disclosed previous difficulties associated with depression. You know, it again, or ADHD, as Damon typed. I mean, it could. The more data that you can collect, and not just collect, but make sure that you present it with within this assessment, because you are typing this assessment up. In essence, think of it like this: you are not typing this assessment up for you. You are typing it up for everybody else that's going to have to read it in regards to their affiliations with this particular case, whether it be for me or for Scott or for Damon or for other clinicians or counselors. If you're a professional counselor and there's also a supportive counselor on the case, they're going to be reviewing this. And let's not forget about Medicaid coming in and auditing, or the state of West Virginia. You know, this is going to be the first thing that they read in that file, because they're not going to come in and start reading your counseling notes until they've read the assessment, because the assessment is going to generate the medical necessity and the diagnostics, which is going to generate the treatment plan, which is then going to be the foundation for your actual counseling notes. History of mental illness in the family. If it's a yes, who was it and what was it? It's very possible there might be times when your patient says, yeah, well, you know, I know my mom had some problems with some anxiety, but I don't really know specifics about that. You know, put that there. You know, just because they don't know specifics doesn't mean that it's not relevant. And again, you are in that particular section. You're not, I guess, the authoritative agency in that. It's not up to you to research it to determine whether or not it's true. You're just reporting what the client is sharing to you. And if you have a client who reports that there was mental health present in their family history and it happened to involve the mother or the father, well, on some level, how did that impact their abilities to function as it relates to parenting practices for your client? Again, pattern, and we are showing a you know, the route or the pathway of the pathology for the client and how they're presenting. History of harm to self or harm to others. You know, pretty self-explanatory. If it's yes, when was it? What was the method? You know, what was what occurred as a result of it. Are there current ideations taking place? If there's current ideations taking place, or if the client reports suicidal ideations, it's always significant to make sure you identify when the most recent event was. When was the most recent ideation? Or if they state that they have attempted suicide 5 times in the past, well, how was they when they started, and how long ago was the most recent attempt? You know, this is significant as it relates to, of course, intervention and treatment.
Boy, my spelling is terrible.
It's all right. As Damon's typing, like if you have a patient who's reporting suicidal ideations, the clinician, what areas do you need to automatically migrate to determine? Are the thoughts fleeting thoughts? Are they having specific thoughts, and those thoughts encompass a plan of action? Well, I'm thinking about killing myself. Well, I think if I'm going to try to kill myself, I'm going to do it by overdosing on pills. Now, that would be an example of a plan of action that encompasses the specific measure or the method. But then I don't have any pills, so next time I visit my grandma's house, I'm going to go to her medicine cabinet and I'm going to take her pills. Well, that shows what? Means. And then I'm going to come home and I'm going to save those pills until next Friday, because next Friday both my mom and dad work late, and as a result of them working late, I'll have more time to do this. So now we're looking at a means and motive and intent, or motive, means, and intent. Now that's you as the clinician are going to need to respond significantly different than if your client says, yeah, you know, I think about it sometimes. It's just like, and my thoughts are, you know, I think my kids would be better off without me, or I think the world would be better off without me, or sometimes I think life's just way too hard. But then the thought comes in, and they have that thought, but then it goes away just as fast. Well, not to say that you don't need to follow up on that, but your course of action is going to be completely different if with that client versus the client who was talking about going to grandma's house and stealing pills and waiting the next Friday because parents work late. You know, any scenario such as that, I would hope that you would notify myself or Scott or Damon and sort of pull us in, not because we think you're incompetent, but it's always better for you to bear the liability. So bring us in and let's staff it and let's talk about it. Outside of suicidal attempts, below that you got self-injurious behaviors, or SIBs. You know, keep in mind that self-injurious behaviors are more than just cutting. It could be also behaviors such as a younger child during tantruming, are they headbanging, or is this particular individual has a cut on their arm or a scratch and they pick at it to prohibit it from healing. You know, what is the self-injurious behavior? What purpose is it serving on behalf of the client? You and I both know, being mental health counselors, that it is a means of escape by way of the physical pain being lesser than the emotional pain experienced. But there's nothing that prohibits you from being able to ask that client what, in their own words, what's the gratification behind displaying that behavior. Now, again, you may have some clients who don't answer that question. You might have some clients that do, but there's nothing that prohibits you from asking the question, and that's okay. Homicidal ideations, I want you to approach it the same way as suicidal. These next sections, it's similar inquiries need to be made, such as like the cruelty to animals, fire setting, things of that effect. When did it occur? Most recent, implemented method. All of those things are just as significant for all of these sections. Now, these sections, what we're looking at here is, again, the pattern, being able to track the pathology, being able to identify potential origins or causal factors from past experiences or displays up until current day presentations. Again, we're filling in the picture frame. This helps us to understand integration as it relates to that specific pathology. You know, are we looking at something more than just a presentation of depression? Are we looking at possible prerequisite type behaviors associated with certain personality disorders? You know, keep that in mind as we go through like this next section. If you have a person who's engaging in cruelty towards the animals, there's not a whole lot of a difference between animals to adults. An older gentleman, a psychiatrist once told me the only thing that's different between maladaptive behavior of cruelty towards animals versus that person engaging in cruelty towards adult or humans is time. So that's the only variable that's different between the two. I'm going to let you catch up. Fascinations with weapons, same as the others. You'll see what Damon's typing. All of this would be examples of significant data that needs to be acquired in regards to it. A box checked yes. Your fascinations with weapons, past or present. Types of weapons, access to weapons, security of weapons in the home, training with weapons. Hey, Damon, I got like 10 after 11. Is there a way that we can sort of call time out and pick up on this and finish it out?
Yeah, absolutely. I didn't even realize that.
I did.
So yeah, let's just, I'll save this document, and I kind of, got halfway through this and kind of realized a little bit more of what we wanted on this. I started out thinking that we wanted to just do an actual person, but then obviously when we get into areas of the assessment that don't apply to this character that I had in my head, I see that now we can actually just fill in some of this stuff with more example type information. So maybe Mike,
right.
I'll save it, and that'll allow you, if you want to go back in and add what you want, so we can go through what we've already done next time pretty quickly, and then we'll get down into the where we left off today and pick up with more discussion on some of the other things.
Sounds good.
Okay.
And I appreciate everybody